Welcome to the webinar today. We're glad that you joined us. We will be talking about with Sue Ginn, and we will be discussing how their practice achieves a MIPS score of 100%. Next slide, please. The ADAM Alliance is a 5-state alliance composed of 3 non-profit healthcare quality improvement consulting companies. We hold contracts with the Centers for Medicare and Medicaid Services, in which we partner with healthcare providers, stakeholders, and beneficiaries to accomplish objectives geared toward meeting the national quality strategy aims: better, more affordable care and healthier communities. As part of these efforts, we help eligible clinicians and groups better understand and successfully participate in the quality payment program by offering free technical assistance, tools, resources, and educational events. We welcome participants from our alliance states of Alabama, Indiana, Kentucky, Mississippi, and Tennessee, as well as anyone else that was able to join us. Next slide, please. If you have questions or comments, please remember to press star 9 to raise your hand. Please introduce yourself and your facility. Feel free to enter questions and comments directly into the chat at any time. We will be asking the audience to participate in polling questions during the event. They will pop up on your WebEx screen. Please participate, and remember to click the submit button to record your answer. Next slide, please. The proper polling question. We want to know from you all, what is your 2018 MIPS reporting goal? You can see there, not eligible due to MIPS exemption, QC status, etc. Eligible, but not reporting. Or report just enough to avoid a payment adjustment, or if you're striving for maximum possible positive adjustment. And we'll give that just a minute. We'd like to give everybody about 30 seconds to respond to that. And then we shall have the results pop up on the screen. And don't forget to hit submit so we can capture your response. While we're waiting, we can go to the next slide. We have a second polling question for you all. Oh, here we go. Okay, our results have popped up. So we have several. We have reporting just two folks just reporting enough to avoid an adjustment. And then we have 7 folks who are striving for maximum possible reimbursement. Okay, thank you for participating in the poll. Okay, so for our second poll, we're interested to know if you've viewed your preliminary MIPS score yet. And I'll give you just about 30 seconds to take a minute to complete that. If you have not, if you answer no to this question, if you could follow the link to the ppp.cms.gov login, and you will need your Enterprise Identity Management user ID and password to log in, and you'll be able to take a look at that MIPS score there. So again, I'll give you a few minutes just to respond to that. And we do appreciate you participating in our polls. It helps. It's a really good guide for us to get where you are. Okay. So I'll give that just a minute while the results pop up. I know they're generally pretty quick. And I'll just give you a minute. In the meantime, oh, here we go. 4 out of 30 folks have reviewed their report, and 4 have not. So I encourage you, we put the link in the slide, and so that you can take a quick look at that and see how you've done. Okay, thank you for that. If you can move to the next slide, please. Okay, next now it is my pleasure to welcome Sue Ginn. Sue is an RN, Quality Improvement Specialist and Analyst with Methodist Physician Group in Kentucky. Ms. Ginn is going to share how their organization was able to achieve 100% MIPS Score for 2017. Sue is an RN with many years of varied experience, including physician offices. In 2012, she began her first job focusing totally on quality for a large physician group, reporting the old PQRS, and then working with the Medicare Shared Savings ACO with a major focus on provider education. She joined Methodist in January 2016 as their Quality Improvement Specialist and Analyst, responsible for ambulatory provider education, MIPS reporting, and manual audit of provider records for employed providers. We would also like to thank the Kentucky Regional Extension Center, which is part of the Great Lakes Practice Transformation Network, for nominating Sue and their practice to speak today. Sue, I turn it over to you.
Thank you. Okay, welcome, and hopefully I can share a little bit some of the ideas that we found that worked for our organization on helping us to achieve the 100%. You'll see the objectives here, and I'm not going to read those, but first of all, I want to say that we have a total of 42 employed providers that include the PCPs, the general surgery, orthopedics, OBGYN, gastroenterology, and we have one hematology oncologist and then some pediatricians. And we have a total of 19 clinics. We have 2 hospital campuses, one here in Henderson and then one in Morganville, Kentucky, which is a critical access facility. Also, our Morganville clinic is a rural health clinic as well. One of the things that kind of challenged Kentucky Regional Extension Center when we first started working with them is because our primary care physicians are part of an APM or alternative payment model with the next generation ACO. And then we have our specialists who we had to report MIPS on. All of our providers, whether they're employed or whether they're contracted, such as our hospitals, anesthesia, ER, we've had a pain clinic at one time, cardiology, endocrinology, several different specialties that are contracted, and we do the billing for those, so they all fall under our tax ID number. So we had to report in 2017 on 168 providers. Because we were supporting reporting for 168 providers, we felt like the easiest and the best way was to use the CMS web interface to do our reporting. We also chose that because we did that dreaded thing of changing EMR systems in August and September. And because we were changing, we knew what they said we could get report-wise out of our new EMR, but we weren't 100% sure that we could get all the data we needed to be able to report successfully for 2017 reporting year, and we didn't want any mess-ups. When you report using the web interface, you do have to report on 14 measures. The nice thing about that is, you know, from the very beginning exactly what 14 measures you're going to report on. CMS tells you what beneficiaries you're going to report on, and they're going to tell you what they want on each one of those beneficiaries. So if Jane Smith was one of our beneficiaries to be reported on, we might report the diabetic measures on her and whether or not she's a fall risk. But John Doe, we might report pneumonia and flu vaccine and maybe medication reconciliation post-discharge. So it makes it hard, but it makes it much easier in my point of view. Also, through the web portal, we were able to attest for our improvement activities that we've done during the year. And then our information systems had access to the web interface, and they attested for advancing care information, which now they've changed the name to Promoting Interoperability Performance Category. I don't know why CMS thinks they need to change things. And one of the biggest things that I think was a real key to our success was because our senior leadership and our board of directors realized the importance of successfully reporting, and they were willing to embrace it and buy into it and help make it come to a reality. In 2015, a restructure was done among the physician group to allow the full-time position of the quality improvement specialist, which is me. And also, in 2016, we piloted one care coordinator in 2 of our clinics. And that was such a success with hospital follow-ups, transitional care visits, getting annual wellness visits, closing some gaps and all, that then in 2017 we added 4 more care coordinators, which had been the plan if it was successful. And they have been a huge addition and blessing to our staff. We also, I report regularly, can't say that word today, to leadership and our board of directors to tell them what's going on. Also, in 2014 and in 2015 reporting years, Methodist Hospital had gotten, our physician group had gotten a 2% penalty because they didn't report PQRS. Then we did report PQRS for 15 and 16 after I came, but because the education was missing on the providers, we still got a penalty for 2015 reporting year, which we took in 2017. When I reported for 2016, we didn't get a penalty. So this year, 2018, is our first year with no penalty since the penalty phase began. We are counting on a potential bonus and positive adjustment in 2019 for our 2017 score. We're counting on a share of that $500 million bonus that CMS is going to give, and we're also counting on a potential bonus up to 4% because of our score. Another thing that we did that has helped a lot is that we chose a physician champion. This is one of our primary care physicians who, he was not our top scorer on the manual audits that I do on their records, but he was a solid scorer, and he was also well respected by our medical staff. And so he works with us to explain to the physicians and to kind of get their feedback on areas that they're struggling with to see if he can help them in any way. Also, another thing that happens starting July 1 of 2018, which begins our fiscal year 2019, their contracts will be affected by their quality performance. So they actually have the opportunity to get bonus money in July of 2019 if they perform well, not only on the quality measures, but also some coding and attending meetings and different things like that. There are several things that are built into it, but quality is tied to their contracts. So they have a lot more at stake and drive maybe to perform well. I think one of the major key things to success of any program is education. You know, we elected, even though we have 168 providers that we report for, we elected to focus on our 42 employed providers with a lot of focus on our primary care. We have some patients that I think in 2017 reporting, we had 3 or 4 patients that were not assigned to one of our employed providers. So that was very few, and they were actually assigned to a hospitalist and one to our endocrinologist, and I know at least one to a cardiologist that is a contracted employee. So that really helped a lot because they understood and knew what was expected, the correct way to document, to meet those measures for the CMS web interface. Also, twice a year I do a manual audit and I look at 15 records for all of the providers to see how well they're doing on the 14 measures, to make sure that they're understanding it. And then if they score less than 75%, which is our guideline for doing that, I have a one-on-one meeting with them. And if they score less than 50, which we've had a few do that, but thankfully the last couple of audits we've had no one be below 50. Then they meet with the quality champion and myself, and we have to do action plans, and they actually get monthly reviews then with lots of feedback on ways to improve. We've just completed a very large training that we had for the PCPs and the clinical staff in the PCP's office, and making sure that they totally knew where to document the items that we needed to report on in January of 2019 for 2018. We also did the same training for all of our specialty physicians as well as our pediatricians. Granted, we don't have to report to CMS in the MIPS reporting our pediatricians because they don't have Medicare patients as a general rule, but we have to report HEDIS measures on them via our health plans. So we wanted them to make sure that they knew how to do it as well, because with our health plans, that's where some bonus money opportunities come from. We also share with all of the physicians, and it's printed in our newsletter, physician group newsletter, unblinded graphs that shows their score. It shows a graph what our aggregate score was and where they fell from the low performer to the top performer. And that drives a lot of competition among our providers because nobody wants to be that low man on the totem pole or low woman on the totem pole. So that I think has driven them to do better and to perform better for the measures. Also, we have one-on-one education with the providers and with your clinical staff if they need it. You know, when I go out to meet with the providers, I try to get them to incorporate their CMA or RMA or their nurse, if it happens to be a nurse, with them in that meeting to help them understand exactly what that measure is wanting. You know, so one of the measures that's kind of hard is the BMI follow-up plan. So they think they could just say diet and exercise, but that's not specific. So they've now learned that they need to tell them how many calorie diet or a DASH diet or a Mediterranean diet, or refer them to a dietitian or something like that. Also about giving them specifics on their exercise, how much they want them to exercise in a week. So physicians now and nurse practitioners, PAs, they all understand now what is required. They also understand that, you know, if you have a depression screening, if your PHQ-9 has a score of 1 on it, you have to address that in the notes, and often providers don't do that because a score of 1 on a PHQ-9 really is a negative score in most providers, in my way of thinking, but because it is a score of 1, they have to address and make some comment. And most of the time it's, maybe they're having trouble sleeping and they gave a 1 because they have to get up to use the restroom during the night, or they have joint issues and they have to get up and move around. Their pain might wake them up during the night. Also, any of our providers, as I said, who score less than 75, they're required to do an action plan and turn it in to us, and that becomes part of their file then. Okay, my slide's not wanting to go. My slide's not moving. There it goes. Okay. Resources. What kind of resources do we need? And this is something that you do not begin this journey without. One, I highly recommend getting you a macro team together. Ours is actually called a macro ACO meaningful use team because we report meaningful use for our Kentucky Medicaid. And then because we have providers in the ACO, we deal with that in our team meeting. And then we have our macro MIPS. And this is made up of billing, so we can get our cost in there. It's made up of IT. We've got several IT people in the committee. Myself, the clinical coordinator, our clinical manager, and then our operations manager are all part of this team to make sure that we're doing all that we need to. And we try to make sure that each month that we're online. During 2017, we actually met every 2 weeks to make sure we were ready for that MIPS reporting come January 1. Our care coordinators in our primary care offices, they have been such a huge help with this because they bring those patients in for their annual wellness visits. They see what gaps they might have in care, so they're talking to them about their mammograms or their flu or pneumonia vaccines, about their colonoscopy. And so that helps us to do better on those measures because they are working with them kind of one-on-one to encourage them to have those. And they're reminding the providers what they need to be done. Patient tells the care coordinator no, and the provider really talks to them about it to try to encourage them to have that test. I attended every conference and webinar that I could find that had anything to do with MIPS. When I went to my first conference in 2016 that was actually put on by the REC, I walked away terrified of what we were going to have to do. By September of 2017, I was feeling pretty good about what we had in place and how well we would do. I wasn't real sure how well we would do. I never expected us to score 100, but I knew we were going to do well, and my goal was for us to be able to share in that and get a score of at least 70 or above. Also, we got a lot of help with our next generation ACO staff because they were constantly reminding our primary care providers about the measures that they have to report on, which are the same 14 measures that we report on via the web interface. So it really helps to have them reinforcing to our providers what we're reporting on. And then, like I said, Kentucky Regional Extension Center, I cannot tell you what a valuable resource they have been. Have a question, pick up the phone or send an email to them and say, this is my question, what do we need to do? And I have gotten some responses back. We don't know the answer to that, but we will find it, and they do. I've never asked a question of them that they did not find the answer for me. So I highly recommend, if at all possible, to partner with someone out of the Great Lakes Practice Transformation Network or the Kentucky Regional Education Center if you're in Kentucky. And then our QPP. has a wonderful resource library. And you can just go onto the QPP website and you can find all sorts of wonderful documents to read, webinars to listen to that may have happened last year, but they're there and we can still read them. After I sit for a minute on a slide, my slide doesn't want to advance. Okay, what have we learned and what would we maybe do a little bit different? As I said, education is a must. You have to make sure that all of your providers and the staff that is going to report or help you either collect the data or whether it's IT that's going to attest for the promoting interoperability piece, everybody has to have a good handle and understand what is needed and what is expected of them. If at all possible, don't change EHRs during the measurement year. That was not an easy task at all. Not easy. Start the day you get your if you do the web interface. Look at those names the day they hit that you get that email saying they're online. And usually it's somewhere around the 7th or 8th of January. At list and start working on it. Don't put it off till the end because it takes a lot of time to find that data. I have to say I'm used to the old PQRS our G-Pro web interface, and it was a nightmare to use in a lot of ways. It was very slow. It was hard to use. You would drop the connection in the middle of entering a patient, and you'd have to re-enter. The new web portal is wonderful. Also, even though, yes, we did score 100 on ours, and we got 60 out of 60 on our quality, we got a bonus point because when we entered it when we downloaded the Excel spreadsheet that CMS provided to us with all of the measures and all of the beneficiaries on it, we put what we found right onto that CMS Excel spreadsheet, and then we could drag and drop it into the new web portal. And on those that we dragged and dropped or used the Excel spreadsheet to send it to CMS, we actually got a bonus point. So that helped greatly to get our CMS score of 60 out of 60. We also make sure that you educate your providers about the importance of coding accuracy and coding to the greatest detail that they can when they see those patients. We found that we had some patients that would fall in our thing for maybe the IVD and whether or not they were taking an aspirin. Well, we could find that in 2015 they had coded that diagnosis of CAD, but they didn't code it in 2017. So we had to, say that we could not confirm the diagnosis because we didn't have anything in 2017 where our providers, and maybe we didn't have something from the cardiologist in our notes that said they had that disease. Same thing with hypertension. Had a couple of diabetics that we could not confirm the diagnosis because it wasn't coded. So those are the type things that your physicians and your practitioners, all of your providers need to understand the importance of coding and dropping those chronic conditions. Also, it's going to help to keep our cost for treating those patients. The sicker the patient is, the more money CMS is going to allow on our cost for treating that patient. And, of course, we can't falsify any records. I'm not saying that, but if that patient has hypertension, be sure and code that. If that patient is a diabetic with peripheral neuropathy, be sure that it's not just diabetic controlled, but it's diabetes type 2 with peripheral neuropathy or diabetic retinopathy, whatever disease process they have, make sure that we're as specific on that coding as possible. Also, teamwork. I could never have reported had it not been for the people here in the office that helped me to find the data. We worked as a team. There were 3 of us that worked as a team to find that data. And then we would go back and look to see if we could find something that the other one had not found. So it was great work there. Also, our EC helped us a lot with this to make sure that we had all of our documentation in case of an audit by CMS. So as soon as we finished reporting, the 3 of us that had worked on it met to make sure that we had all of our documents, everything that CMS or our EC had said that we needed to keep. We went through that and checked it off and put it all in a binder, backed up our things on a external hard drive, thumb drive, so that if we're audited during the next 7 years, we have our documentation for everything that we did. So make sure you keep your documentation. And that is the end of my presentation. I'll pass it back to Deborah or whoever is going to do the next part.
Thanks, Sue. Yeah, thanks for that informative presentation. It's very helpful. We do have a couple of questions in the chat, and I'm not sure if you can see the chat window. But one question we have from Cynthia, and Cynthia, I'm trying to summarize a little bit here. So she's asking, do you submit your macro measures on through the web interface for some providers? And then what about your ACO providers? How do you do that? Do you do it all through the web interface? I think they may be part of maybe an ATM or an ACO. I'm not sure because I think her sentence got cut off.
Okay.
Do you submit separately?
The next generation ACO that we're part of, they actually get the list from CMS of what has to be reported on all of the many physicians that are part of their ACO. And so they report, they have access to our EMR, so they can go in and find what they need to report for any of our providers that are in the ACO. Now, some of our primary care physicians who are part of the ACO had patients assigned to them on our web portal. You know, patients have the right to decide not to be part of an ACO. They can say that they don't want to. So those patients would fall in my reporting. Or a lot of times they may have been attributed to, say, Dr. Hussein, our oncologist, but they are a patient of one of our primary cares. So what the primary care had documented in the record, because we're all on one EMR, and we share that, so we share records, so we could use their records, whether it be a depression screening or an A1C, any of that we could use to report for any of the patients that we were attributed. I hope that answers your question.
Yeah, I actually looked further down. I was looking in the window, and it looks like that's what she was at. So some of your providers are part of the next generation ACO, and they submit our group of 75 providers for us. So she's saying, I think, as part of the next generation ACO, they do the submission report out for 75 providers for them.
Right.
Yeah. Okay, we have another question, and it's from Faten, and she says, we just joined an ACO this year. Are we supposed to report on our assigned patients only, or report all of our data as we used to do in the previous years before joining? Can you answer that question? Or that might be for some of our panelists, I don't know, that are on.
You know, I think it would depend on what the ACO is going to, whether they're going to report and whether or not all their providers are part of that ACO.
Okay. Okay, and I don't know if there's any of our experts that are on. I know there are several on the call. If they would have any other advice on that or not, we have several of our team members that are on that might respond to that. I know they can take themselves off by star. I think it's star 2. Okay, and I actually had a question too, and I know you touched on this about what drove the change, because you definitely didn't recommend the Hannah reporting and changing your EHR. Was it because of the reporting function that you were not getting accurate reports out of your EHR? Is that why is that what drove the change?
Yes, the EMR that we were on when, after I attended the very first macro meeting and came back and talked to Amy Molly, who is the clinical coordinator or manager, and she was very, very familiar with our old EMR system. And I said, can we pull all of these reports and can we end-to-end report using our current EMR? And it was decided that we could not do that through our EMR system. And because each provider could customize their templates and make them any way they wanted to, there was no uniform place across the board for all of our providers to maybe document their depression screening or their mammograms. We had no way of pulling that out of our old EMR. So that's what drove our change.
Okay.
And hopefully by the end of 18, we're going to be able to get a lot of it by running reports straight out of our EMR.
Yeah, I mean, that sounds like a good plan. I mean, you've got to be able to get your data out, accurately. So that sounds like I'm sure it was a considerable expense and workflow and that sort of thing, but for the future, I'm sure that was probably a good move for you all to do. So I had another quick question, that I also wanted, you said, we know that providers are often competitive, and you did the unblinded sharing. How was that? How did that go over? Were the providers okay with that? Did you have some resistance in the beginning?
Well, actually, the very first one that we presented unblinded was kind of an accident. We were having our primary care or family practice governance meeting where all of our providers attend. And the VP of the physician group, I had sent her one with the names on it, one blinded and one unblinded. Well, she happened to put up the unblinded one in her presentation instead of the blinded one. And she really had not meant to at that point. But one of the providers who was in attendance that day was devastated because she was the lowest performer. And so she came to my office and she said, I will never be there again. What do I have to do? Help me. Tell me where I messed up. Tell me what I can do. And I had tried to meet with her prior to that, and she was semi-engaged. But after she saw her name and all of the other providers were able to see her name at the very bottom, it changed her whole outlook. She said, I won't ever be there again. And she has not. That is what it took for her to buy in and say, okay, what do I have to do? How can I make this work? How can I do better? Right. So I think because they're competitive, they wouldn't have made it through med school had they not been competitive. Might not have even gotten in. And so it really has helped. And we use the same unblinded approach at the large system I was at from 2012 through 2016. And all of our data was presented unblinded.
Yeah. Okay, are there any other questions for Sue? If so, please type them into the chat box. I want to thank Sue for her informative presentation and for sharing her success with me. And I want to thank everybody that's attended the call. We do have some resources and documentation available. You can see them listed here, and we've put them in the chat for you so you can directly click on the link to obtain the resources. And I highly recommend the EIDM user guide, both guides, and we know that was one of the big challenges for folks was to get access to their EIDM account. So we just want to make sure that everybody's well versed in that for this MIPS reporting year. And also, the video and introduction to the CMS web interface video is a very useful tool. And of course, the MIPS data validation criteria, which we touched on earlier, that is another really good resource for you all. So we just wanted to make sure that you have those resources. Okay. Next slide, please. And we just want to let everybody know that we are here. We are free technical assistance. We are available to you. There are several other resources. The Medicare Learning Network is several educational opportunities for you to review there. And there's also a resource center website. We have providers.exchange. Please take a few minutes to check that out. We are able to offer free assistance to providers, and we have a help desk, and we have an email support address listed here, and you can also reach us by phone, and that number is available on the slide for you. Next slide, please. You can connect with us in several ways. We have Facebook, Twitter, LinkedIn, and Pinterest. And I just want to thank everybody again today who participated on the call. If you have any questions about what you've heard or if you need more information, please feel free to contact us by any of the methods we have shared. And I'm going to say Sue has offered her email address if you would like to email her, and I'm just going to put that in the chat for everybody. And I want to thank everybody. We are holding these office hours calls the fourth Wednesday of the month from 2 to 3 Central, and we look forward to hearing from you and in next month. So thank you all.
And that concludes our webinar for today. If you're part of the planning team, please stay on the line for a quick debrief, which will get started in a couple of minutes. Okay, and if you're on the line for our debrief today, as part of the planning team, if you could just make sure that your phone line is off mute by pressing *2, you should hear an animated voice telling you the status of your line. I'm going to go ahead and disconnect any other lines that are not off mute. That would be great if you don't mind.
Okay.
And who else do I have?
We have 18.
Krista, I'm still on. Who is that? Oh, Krista? Eric?
Daniel.
Daniel? Okay, I'm going to go ahead and drop any lines that are not off mute, and we'll get started with debrief in just a sec. Hit star 2 if you're on for the debrief, please. Okay, great.